Good morning. Last week, we started oxygenation concept, right?
Yes.
Which exemplar did we discuss last week? COPD. Tell me what you remember from what we discussed last week. What do you remember?
Don't give them too much oxygen.
Don't give them too much oxygen. Why? What is the rationale behind that? It's going to stop their breathing, right? It's going to suppress their respiratory center. What else? What else did we discuss last week? That was 2-hour class.
Bronchitis and emphysema.
Huh?
Bronchitis and emphysema is part of COPD.
Bronchitis and emphysema is part of COPD. Give me stuff about patient signs and symptoms. Thick sputum. So what do we do about the thick sputum? Cough, turn, and deep breath. What else? Fluids. What else? Mucolytic medications. What else? Antibiotics if they have infection. What else? Short-acting beta-agonists like albuterol to open up the alveoli. And that's the one you give first. What else? What is incentive spirometer? What does incentive spirometer do? Stop the patient from getting pneumonia after, like surgery, she said. So to prevent a lung collapse, right? It forces them to take deep breaths so they can prevent lung collapse. How do we use incentive spirometer? How? How can you teach the patient to use it? Huh? Hold it what? Hold it up, right? Okay. Take deep breath in. Hold it for how many seconds?
10 to 15.
No.
2 to 3.
2 to 3 seconds. How many times do you do that?
10 to 15.
10 to 15 minutes. How often do you do that? Every 1 to 2 hours. Okay. It's important we know how to educate the patient on how to use these things, because if they're not using them correctly, it's not going to work, right? It defeats the whole purpose. So anytime you're educating the patient on how to use stuff like incentive spirometer, you need to be able to teach it right. They need to return demonstration to you. So what else? What else did we discuss last week on oxygenation?
Group their activities.
Huh?
Group their activities.
Group the activities or rest between activity, right? Why do we do that? Why do they have to have rest between activity? What is making them do that? Shortness of breath. What is triggering the shortness of breath? Huh? Lack of oxygenation, right? Lack of oxygenation is what is making them have short of breath. That's why you have to rest between activity. We have to put these signs and symptoms in the patient. Don't learn them separately. Put it on the patient. How does it affect the patient? And what you do and how does it influence the problem the patient has? It is the hypoxia that's making them have short of breath. That's why you have to group activity so they rest between activity. We have to put it on the patient. Okay. Continuing oxygenation. Last week, I went over. You all have the safety paper I gave you last week? We need it. Last week, I went over SLO. And I told you that SLO is what guides the class. The SLO tells you the objective or direction where the class is going. Class, I mean oxygenation concept. And then when we set our exams, we look at the SLO. Another component of what we look at is safety module. This safety module is what the State Board of Nursing do. That's how they set the exams, and we're looking at that. Since we're preparing you to take the State Board of Nursing exam, we follow this safety module. It is important you pay attention to it because we pay attention to it. It guides you on when you study and how to study, so that you won't say, well, I don't think they're going to have any question on medication. Well, I don't understand this. Maybe they're not going to ask you. Yes, they will. Why? Because the safety module says so. Why? Because the SLS says so. So if you look at this safety module, S stands for system specific and reduction of what? Reduction of risk potential. That means you send the patient for a test, patient that have asthma. You send in the patient for bronchoscopy. Okay, that's diagnostic test. When they come back, the doctor have done their job. What is your role as a nurse? What will you do about this patient? Do you know that you have to keep them MPO? Do you know you have to watch their gag reflex? Patient goes to surgery, come back. Do you know that you have to monitor their viral sign? They went for diagnostic test. They went for comprehensive surgery, come back. What is your role? If you look at that, that has 9 to 15%. It's up there. S, safety. Patient safety. A, about management of care. How can you manage your care? Management of care has 17 to 23%. That's what the State Board of Nursing does. Yeah. How can you manage this patient care that have asthma exacerbation that comes to you? How do you know what to do first? When you identify the patient need, which one is more important than the other? How do I know how to treat that patient so that the patient gets better, they don't get complications? F stands for physiological adaptation. These are patients that have acute or chronic illnesses like COPD, asthma, or they come to the hospital with acute phase asthma exacerbation. How will you know what to do? What are you going to do for that patient first to resolve that exacerbation so it doesn't go into the, all the way to patient having status asthmaticus? E stands for evaluation of pharmacological and parenteral therapies. Here comes our medication. How do you evaluate pharmacological concept? It's not enough to give the patient medication. How do you know that the medicine you're giving is working? We're going to talk about inhaler a lot. We're going to talk about prednisone. We're going to talk about all those medicines that will help these patients that have asthma or COPD feel better. How do you know the medicine is working? How do you evaluate that? Because it's not enough to give it to them. How do you evaluate that it's working? You see why? When we ask you those questions, this is why we do that. How do you know that what you're doing is working for the patient? That's why we don't manufacture these things in the air. Teach and practice safety and infection control. Teach and practice. Teach. All we've been doing is teaching, teaching, teaching. You have to teach this patient how to use their incentive spirometer. You have to teach this patient how to use their inhaler. You have to teach this patient how to use their dry powder inhaler or meter dose inhaler. They have to know how to use these things. If they don't know how, then they're not going to get better. So teach, teach, teach. We have to be able to teach those things. And the infection control, you have to wash your hand. You have to educate them how to wash their hand too, how to store their medication, what to do. Do they need to put mask on or not to put mask on? We have to do all that. Then Y has like little percentages. Y, health promotion and maintenance. We have to educate this patient. When you have chronic illnesses, you have to take your vaccine. Pneumonia vaccine every 5 years, flu every 1 year, every year. Of course, cigarette is one of those things causing all these respiratory problems. You need to teach them about health maintenance. Smoking cessation, how to stop smoking. Patients that have asthma, teach them about how to identify asthma trigger so that they don't have to come back to the hospital with the trigger. Another why, basic comfort care. Educate those patients like patients that are dying. Give them their pain medication. Do not deny their pain medicine. This is not the time to say, oh, the respiration is down, I'm going to hold the pain medicine. Give it to them, they're dying, they need to die painlessly. So those things are stuff you have to pay attention to. The last why, psychosocial integrity. There are occasions the patient might come to the hospital for something else. Maybe patients that have elimination issues. They come to the hospital thinking that they just have little nausea, vomiting, but then they're going home on colostomy. Wow. That's a severe psychosocial issue right there. That patient, how will they deal with that? That's why when we ask you all those questions, like how the patient feels about something, you don't ask question with question. You have to kind of acknowledge the patient problem, acknowledge what is worrying them, give them more opportunity to explain themselves. What will you do about this? The patient is complaining about something. What will you do? That's why we ask those kind of questions. Give them more opportunity to explain themselves. Don't ask, well, do you think if you do X, Y? They don't want question for question. They want answer for what they need. So we're going to pay attention to this safety module in addition to our ACLS. So our concept today is asthma. How many of you have asthma or have somebody that have asthma or have taken care of patients that have asthma? Do you have asthma or you know somebody?
My son.
Oh, okay. So tell us the signs and symptoms your son has. Because how old is your son?
11.
You're going to find out there's no difference whether they're 11 or 111. They're going to present with the same signs and symptoms because it's what? Asthma. Asthma. Okay. So what is the sign that your son has?
My son has, he gets a severe, like, croup sounding cough.
Okay, we're not going to use the word croup because now we're talking about children. So we're going to just say coughing. What else? Somebody, anybody? Shortness of breath, breathlessness. When it comes to asthma, we call it breathlessness. What else? Wheezing. Wheezing is a classic sign of asthma. What else? Do you think they're going to have tachycardia and tachypnea? Why? Well, they're anxiety. But do you think they're going to have tachycardia and tachypnea? What is causing tachycardia and tachypnea? Lack of oxygen. So do you think they're going to have that or not? Yes. They're going to have that. Tachypnea, tachycardia. Then anxiety. Chest tightness. Feeling of the doom, feeling of doom. They're going to have respiratory alkalosis. Okay. When a patient have asthma, what is happening? Asthma is irritation of the airways. It is hyper-responsiveness to a trigger. Any trigger that we would identify later is what triggers the patient to have asthma. Somebody that have asthma might be sitting in the class like this. It doesn't mean that they have asthma for the rest of their life until they have a trigger. What does the word trigger means to you? Just English word trigger.
What makes something happen?
What makes something happen? You always hear of, oh, who pulled the trigger in the gun, right? You have to pull the trigger for the bullet to exit. If nobody pulls the trigger, the bullet does not exit. So there's something that's making something happen. If you don't have a trigger, your asthma will not be exacerbating. It will stay dormant. It won't cause any problems. It's only when that patient have a trigger that it irritates the airways, the patient will feel like doom. There will be crushing of the airways, chest tightness. They feel like their lung is not expanding because of narrowness of the airways from inflammatory responses. Remember, when you have inflammation, what do you have along with inflammation? Anybody? Infection, what else? Bronchoconstriction. You're going to have swelling. The same inflammation that you have any part of the body, the same inflammation you're going to have from the trigger. They're going to have swelling. They're going to have redness, infection. Because of that swelling, what do you think it's doing to the airway? Constricting the airway. When you constrict the airway, do you have adequate oxygenation getting in? No. So because you have reduced oxygenation getting in, the patient will start hyperventilating. That squeezeness, less oxygenation going in, patient is going to start having hyperventilation. So we can add it here, hyperventilation. Before we even delve into these signs and symptoms, let's look at what triggers asthma. What triggers asthma? What makes asthma flare up? Huh? Pollen. Pollen. What is it? Pollution. What else? Respiratory tract infection, gastroesophageal reflux diseases, dust, pet dander, smoke, exercise, carpet. That's why it's important to identify what the trigger is. Even dead roaches. I know. Yes, ma'am.
Under dust.
Dander.
Pet
Pet dander.
dander.
Really?
Medication.
It could be anything you're allergic to, right?
Anything. Medication. So the rule of thumb is for this patient to identify what the trigger is. Identify this trigger and stay away from the trigger. If you have carpet in the house that collects dust, that makes the patient have triggers the asthma, remove the carpet, put tiles. This is Louisiana. There's always dead roaches everywhere, no matter how clean your house is. Have you ever woken up one day, you wake up, you saw a roach like this with the head up? You'll be like, what the heck? Where did this come from? You thought your house is sparkling clean, but it's Louisiana, New Orleans. So what happens is those dead roaches, they crumple up. When they die, maybe it's hidden under somewhere you cannot reach. When you put the air conditioner on or AC on, it blows everything. It has particles in the air. You cannot visualize it with your eyes. Somebody who is allergic to it can pick up those dust and it can trigger their asthma. So find out what the trigger are and stay away from the trigger. Respiratory tract infection can do that. Gastroesophageal reflux can do that. You have food backing up from the esophagus to the trachea. That can stimulate and trigger asthma attack. Dust, fumes, exercise. It's very important before you exercise, notify your doctor. Use your inhaler before that. And notify your doctor before you do any form of exercise, because you don't want anything that will trigger your asthma attack. Any question with this trigger? So now we are looking at these signs and symptoms. Do you think there's any difference between treatment of these signs and symptoms and the treatment of COPD? No. Is there any treatment? If somebody is coughing, does it matter what is causing the cough? No. The same signs and symptoms, the same treatment. They're not breathing. What is making them have this breathlessness? Lack of oxygen because of constriction. So what do we think we need to do? By giving them what? Medication, albuterol. Give them the albuterol inhaler, the first one. Short-acting beta agonist. We're going to talk about medicine in details, though, but right now let's kind of plug it to the signs and symptoms. Wheezing, give them medicine, of course, oxygen. Tachycardia, tachypnea is hypoxia that's causing that, so give them oxygen. Anxiety, what do we give them? Med. What kind of medicine? Anti-anxiety, we discussed in COPD, the same treatment, the same principle. If they have anxiety because of hypoxia. Give them oxygen, give them medication. Chest tightness, if you give them their medication and the oxygen, it's going to resolve the chest. It will bronchodilate. Then the chest tightness will go away. That will increase the oxygenation. They will feel less doom. Now, respiratory alkalosis, we're going to talk about that in detail when I talk about acid-base imbalance. These two, respiratory alkalosis. They hyperventilate, those patients that have asthma, but I'll talk about it more in acid-base balance. So any question here? Okay. So with asthma, it's very, like I say, it's important to identify the trigger, stay away from it. Let's look at diagnostic tests. Diagnostic tests. What kind of test do you think we have? Pulmonary function test, arterial blood gas. What else? X-ray. Peak expiratory flow rate. O2 monitor. Bronchoscopy. Okay. Pulmonary function test. What does the word pulmonary mean to you? What is function? Just the English word function means what? How it works. So pulmonary function test is a test that's done to see how the lung what? Functions, how it works. To see if there's mucus occluding the airways, to see if it's clear, if it's not clear, just to see how the lung is functioning, to see how much the type of medicine that will be prescribed. We're going to talk about arterial blood gas in details. X-ray, what do you think they do X-ray for? If they have fluid in the lungs, to see if they're developing pneumonia, to see what kind of antibiotics they need to give the patient, to see what is going on in the lungs too. Peak expiratory flow rate. What is peak expiratory flow rate? What is peak? What does the word peak means? Huh? The highest. Expiratory means what? Breathing out. Flow means what? How much? And rate means what? Speed. That's all it is. Peak expiratory flow rate. See, sometimes these words, they put it, I don't know how they make all this stuff so big, but it's just simple English language. Peak expiratory flow rate tells you how much air the patient can exhale in 1 second. Because if they're not exhaling enough air, what do you think is happening? There's occlusion, right? There's occlusion in the airways. So we need to measure how much air they're exhaling out. When a patient has asthma, they have issue with inhalation and exhalation because of that chest tightness. They have problem with inhalation and exhalation at the same time. So this peak flow meter is what we use for that, to measure expiratory flow rate. When a patient has asthma and they don't have exacerbation, at the point when they are okay, they're not sick, there's no exacerbation, they need to do this peak expiratory flow rate and establish their own baseline. They need to do it at least 3 times a week and add all those 3 and find an average. That average becomes their personal best, what we call personal best, or what you can say is baseline. We call it personal best or baseline. When you have this baseline, it's very important that every patient that have asthma finds their baseline, so that when they are in trouble, when they start having exacerbation or they wake up one day, they don't know how they feel, it becomes important that this tells them the next level, what to do. So, what does the, like in the traffic light, what does green mean? Go. What does yellow mean? In a normal person that obeys rule, caution, slow down. Red means what? In a normal person that obeys rule, stop. So green means go. You want it to be 80 to 100. You want this number here to be 80 to 100, 50 to 79, less than 50%. They're all in percent. So after that patient have established their baseline, that baseline becomes a marker for them to see where they are. So that if they wake up one day, they take a deep breath in, they blow it into this peak flow meter forcefully in 1 second. If the marker, their breath, is between 80 to 100, it's green. That means what? Go about your business. Do what you have to do today. Do not call in sick. Go to work. Stop looking for excuses to stay home. Go to work. It's green. Green means what? Go. But if you wake up, you say, I don't feel right today. I just don't know how I feel today. You take in a deep breath. You inhale, you exhale it here. It's between 50 to 79. It means what? Caution. This is the time for you to use your what? Inhaler. Use your arbitral inhaler and watch yourself. Remember, arbitral inhaler is fast acting. It kicks in minutes. And how often do you use it? 4 to 6 hours. Okay? So you did the inhaler. 4 hours, you're fine. Well, then you don't need to do anything else. But if you use the inhaler Next 2 hours, you feel like you need to use the inhaler again. What do you think is happening?
Not working.
It's not working. What do you think you need to do again? Do you go ahead and do the inhaler, or you go ahead and do the expiratory rate? Expiratory rate, because the inhaler is what? 4 to what? 6 hours. You cannot overdose yourself. So you need to take a deep breath again and exhale and see where you are. If it's in red, less than 50, what do you think you need to do?
Call a doctor.
Somebody say call the doctor. Is that what you do?
No.
What do you do?
Go to emergency room.
Somebody say go to the emergency room. Is that what you do?
Call 911.
Call 911. You see the
I don't wanna
difference?
drive
You
yourself.
see the difference? You don't want to say go to the emergency room or go to the doctor. That means you're driving yourself. And again, if you go to I-10, which happens all the time, there's always some knucklehead that will hit somebody, and then the whole traffic is jammed. And you're driving yourself. Nobody cares about where you want to go. They want to go somewhere too. But if you call 911, guess what's going to happen? Everybody's going to clear the way. The police will unblock the way for them, they pass. Right? So not only you get to the hospital faster, they have medication in the ambulance, they'll be treating you. Zach, you'll be treating them before you get there. Zach and Kevin, you're going to be treating them, right? On their route. That's why you're smiling. So, call 911. Again, this sounds like how the test questions are. You think we're tricking you. But this is exactly how the test questions are. What will you do? Go to the emergency room or go to the doctor's clinic, call 911. You see the difference there? You call 911 because they'll be treating you en route, plus you get there faster. If you're driving yourself, nobody's ready to clear for you in the way. They don't know why you're speeding. They probably think you have drugs. You're running away from the police. So, always pay attention to this, because this is how you educate the patient to use their peak expiratory flow rate. This is what tells them their personal best. So if you give a patient albuterol inhaler, what does this number mean to you? If the number is at 50, is it working? If it's at 50, so 79, is it working? So what do you think the goal is when you're giving the patient medicine? 80 to 100, because that's your goal. That tells you that the medicine is what? Working. It's 80 to 100, it can be no better. So that means the medicine is working. 80 to 100 of their personal best. Remember, that means everybody's personal best won't be the same. Remember, you already established your personal best. But you're looking at the percentages. Everybody's percentage is the same, because it's the percentages of your own personal best. Just like everybody don't have the same blood pressure. Yet we have the normal blood pressure we're looking at. We have high blood pressure, we know the number, we have low. Yet everybody varies in their blood pressure, the same thing. You're looking at that personal best of the patient. You want it to be 80 to 100. That tells you the patient is feeling better now, and that the medicine you give the patient is working. Any questions here? Okay. So, of course, the O2 monitor, O2 sat. O2 sat can be spontaneous, like when you all do oxygen saturation in the hospital with vital sign. It can be continuous. When you have those patients on telemetry monitor, then they hooked up to O2. Continuous means there's somebody monitoring that O2 somewhere with their telemetry monitor. You're constantly monitoring that O2. We do SPOT when we do vital signs. They're both monitoring the O2 saturation of the peripheral of the patient to see how they're doing, to see how well they are oxygenated or not oxygenated, because that gives us the gauge. Bronchoscopy, I already talked about that, to scope. Scopy means to scope, bronchi, to scope, to see what's going on in the bronchial tree. You have to monitor those patients when they come back to you. Make sure they're not bleeding, they're not aspirating. Check their gag reflex before they eat. Because you put tube in somebody's mouth, you have to make sure they have gag reflex before they can eat. Otherwise, they what? They will aspirate. Okay, so far, what have you learned? These 3 lines here, what have you learned so far? Anything you have learned so far? These 3 lines?
Avoid triggers.
Avoid triggers. Okay, let's put all this stuff in the patient. Why are we avoiding trigger? So they won't have exacerbation. Good. These 2 lines? What have you learned so far?
You gotta do a peak expiratory flow rate to know what's your normal. You got a baseline.
You have to use the expiratory rate, peak expiratory flow rate to see what's wrong with them to establish your personal best or the baseline. This line here, what have you learned so far?
They should use the peak expiratory flow rate reading 3 times a week when they're not sick or in an exacerbated state.
They have to use the peak expiratory flow rate when they're not sick to be able to establish their baseline, so that when they get sick, they know where the baseline is when they do not have exacerbation. These 2 lines. Anything.
We'll teach the patient to call 911 if the
Okay.
inhaler is not working.
Let the patient call 911 when the inhaler is not working. Yes?
I was going to say, patient education between 911 and driving themselves.
Right. Educate the patient to call 911, to tell them not to drive themselves to the hospital. Okay, so you're paying attention. Very good. Let's look at the arterial blood gas. Still under diagnostic test. Arterial blood gas.
Is like testing gag reflex, like is that just them coughing, or how do you test?
Anybody? Good question. How do you test gag reflex? Anybody?
And if they choke on it?
No. That's another thing I need to say. We have to be careful how we say stuff in the patient room. I'm about to stick something on your throat and see if you gag. How does that sound like to you? Use appropriate terminology. I see students come in here. Let me do your blood pressure right quick. I don't want you to do anything on me right quick. You have to be mindful of what you say, because the way people tend to do stuff the way we talk. Oh, I'm about to stick you right quick. If you're telling me you're about to stick me right quick, I don't want you sticking me. Oh, let me take this temperature right quick. You know, let's be mindful of those things. I'm about to stick this in your throat. How does that sound like to you?
Painful.
So we have to be mindful of that. Students say that all the time. I correct them. But, you know, we have to pay attention to how we say things. The patient will be like, whoa, don't stick stuff in my mouth. So you get tongue blade. Explain to the patient, this tongue blade, I will depress your tongue to see if you will gag. Just say what you're looking for, say what you mean and what you're about to do. I'm going to use this tongue blade. I'm going to ask you to open your mouth. I will depress your tongue with this tongue blade, see if you will gag. If you gag, that's a sign to me that you're ready to eat. If you don't gag, that means we have to wait. I will come back and check it again. Tell the patient what you're about to do, the way we're doing it, and the rationale behind it. If you are not gagging yet and I feed you, you are going to aspirate. The food will go in your lungs and you will get sick. They don't know what aspirate means. Fluid will go in your lungs, or food will go in your lung and you get sick. But once you gag, that tells me you're ready to eat and everything will flow well because of the test you just have done. Yes?
So you put it like, what do you put it on the tongue? Like a
Tongue blade.
I know, I'm saying, like, what do you place it like at the bag?
In the tongue, in the middle.
Okay.
Depress it. Depress the tongue. I don't want to stick this in my mouth. Depress the tongue and then gag. And then we gag. They do, if they don't do that. Brian, do you know another way of checking for gag reflex beside the tongue? Well, that's what we've been doing for years. All right. So we still do that with the tongue blade. So it's not that hard. And they will gag. Trust me, they gag. They will gag. So I'll be like, yay, it's time to eat. Now I can give you that food you've been asking for.
My son will throw up.
Huh?
I said my son throws up.
It throws out? Okay. Most of the time they won't throw up because they're NPO for the test, so there's nothing in the stomach. So, but children, it's a whole. I'm not a pediatric nurse, so I don't know.
Swab or something.
Yeah, children are a little different. They're a little different. So, what is the normal pH?
7.35 to 7.45.
What is the normal PCO2?
35 to 45.
Okay, good. Because the previous class, I asked them, what is the normal pH? Everybody said 35 to 45. When I said, what is the normal CO2? It was 1 or 2 people. I was like, remove the 7. Just remove the 7. If you remove the 7, it becomes 35 to 45. See the trick on that. So for this patient that have asthma, remember we said they hyperventilate. Hyperventilation. So their pH is always high. So it's going to be 7.48 or 49. It's going to be higher than 7.45. For those patients with asthma exacerbation, their pH is always higher than 7.45 because they hyperventilate. And because they hyperventilate, let me use black so it will show better. Let me use black. Hyper, ER. PCO2 might be like maybe 32 or 31 or something. What is normal PCO2? Remember again, remove 5, 35 to 45. Because those patients with asthma exacerbation, they hyperventilate. They always breathing like when you're running. They're blowing off a lot of CO2. Because they're blowing off a lot of CO2, their PCO2 stays low. It's opposite COPD. COPD, they hypoventilate. They retain a lot of CO2, so their CO2 is high when the pH is low. But here, patients that have asthma, they hyperventilate. Their pH is always high, higher than 7.45. Their PCO2 is lower than 35 because they are blowing off that CO2 when they are hyperventilating. So bicarb might be normal. We can say 26. Partial oxygenation, we might say 70. SaO2, we can say 90. No, 90 is scanner. Let's say 88. So is the pH high or low? When it's high, it's what? Alkalosis. Then again, this is the way I do mine. You can do yours however way you learn to do it is still fine. As long as we get the same result, it doesn't matter. PCO2 high or low? Low. When it's low, is it alkalosis or acidosis? Alkalosis. In alkalosis, the PCO2 is low because they're blowing off CO2. They're hyperventilating, they're blowing it off. So the CO2 has to be low. And again, PCO2 acts like an acid, but in this case, it's alkaline, so it's low. That's more complicated for you. Okay, 26, is it high or low or normal? Normal. Partial oxygenation, high or low? Indicating what? Hypoxia or hypoxemia. Hypoxemia because this is arterial. High or low saturation? Low. Indicate hypoxia or hypoxemia. It could be that. So what kind of imbalance is this? Respiratory alkalosis with what?
With hypoxemia.
Respiratory alkalosis with hypoxemia.
Do we need to know that if it's acute or?
Well, what is it? Acute. Acute respiratory alkalosis with hypoxia or hypoxemia. Why is it acute? Because the bicarb is normal. You still have something that's normal. So that means this is the patient that have acute asthma exacerbation that just showed up in the hospital. This patient just have exacerbation. The kidney have not kicked in yet because it takes kidney some days to kick in, right? You cannot compensate when you're normal in terms of PCO2 and bicarb. Remember bicarb, when you talk about bicarb, you're talking about kidney. It kicks in, takes time to kick in, while respiratory kicks in immediately. So it is normal range, so it is acute. When you have one of these values, PCO2 or bicarb, normal, it means acute. If one of them is normal, that means acute, something that just happened, the body haven't had time to compensate yet. So this is respiratory alkalosis. So this patient is very sick. Always remember, when the pH is normal, the goal of acid-base imbalance is for pH to be normal. When the pH is normal, there is an equilibrium in the body. There is a balance in the body, regardless of what other part of the PCO2 or bicarb is doing. So if, for example, this is, well, for this patient that's hyperventilating, we have to give this patient oxygen. This patient is very sick. We need to treat this patient. This is a patient that needs an albuterol inhaler. When we're giving medication, that's another thing. There are different ways of giving the medicine. It can be through MDI, metered-dose inhaler. Let me do it right here. MDI, DPI, or nebulizer. There are different ways of giving this medication. If it's MDI, metered dose inhaler, how many of you have used this or have? Okay. Okay, tell us how it's used.
With the breathe out all the way, and then if you have a spacer, you want a spacer and breathe out, hold your breath, and then puff it, breathe in at the same time, and then hold your breath also when you take it.
Okay. He said breathe. Now he's coughing. That's good because that's what the medicine makes it. He said breathe out and then use the spacer. Take a deep breath in, hold it, and exhale. Who else?
Don't you need to prime it?
You have to prime it. You have to shake it. What else? So who's going to give me the whole scoop? I have pieces information here, piece of information here, there. Who's going to tell us the whole steps?
Okay, so you prime it, you put it in your mouth, you breathe in as you're squeezing it, breathe out, and you have to wait 2 minutes to do the second puff.
Yes. You have to prime it. First thing you have to do, the first thing you have to do is even establish there's medicine in the canister. Always make sure there's medicine in the canister. This is an old metered dose inhaler that I got from respiratory therapists. The newer ones now have numbers that's calibrated, telling you where you are. It's transparent.
How many puffs you have left?
Right. It will tell you how many puffs you have. This is the old one. That's what I got. But it's the same principle. So you shake it. This is metered dose inhaler. This is spacer. You can either use the metered dose inhaler by itself or use it with the spacer. It is more, how will I say that? With the spacer, it's easier. The medicine gets straight to your lungs. You can imagine if you use this, it looks like the medicine has to pass through your mouth to get to your lungs. But if you use the spacer, it makes the medicine go straight. Kind of bypasses your mouth, goes straight to the lungs. But not everybody gets spacer, you would think. It depends on them crazy insurance company people. So you shake it, take a deep breath, exhale, shake it, put this in your mouth. Always seal the mouthpiece. I'm not going to put this in my mouth. Seal your mouthpiece. Inhale slowly in. Hold your breath for 10 seconds. Exhale. Why do you think you hold your breath for 10 seconds? This side. Why do you think you hold your breath for 10 seconds?
You can actually absorb the medication.
To make sure that the medicine is absorbed. You don't, because if you inhale, exhale. What do you think you're doing? You're exhaling the whole medicine out. Let the medicine sit in. If for any reason you need like 2 puffs, you have to wait between puffs. Have to wait between puffs, then you start the cycle again. Always use the spacer if you have one. If not, use it by yourself, but the spacer delivers the medicine directly to your lungs better. Then another way of giving this medicine is DPI, dry powder inhaler. Dry powder inhaler. Dry powder inhaler, just what it says is dry. It comes like a capsule, like medicine. You think you can swallow it by mouth, but it's for respiratory treatment. You put the tablets in here, close it up. See, once you close it up, it converts into mouthpiece. It will crush the medicine. Then you put, anybody knows how to use this? Okay, explain it to us.
The same way, basically. You put the medicine, you inhale the same way you do with the other.
Okay. That's a little different the way you inhale it. When you inhaling, metered-dose inhaler is slow, deep breath. When you inhaling dry powder inhaler, strong, you have to deeply inhale because it's that deep inhalation that converts the tablets that's in here into aerosol so that you can inhale it. So deep inhalation with dry powder, slow with metered-dose inhaler. You see how that works? We have to understand this concept so we can educate the patient on how to use these things. There are different ways of using them so that the medicine can work for them. Then we have nebulizer. This one you see every day on every patient in the hospital. This is nebulizer. They put the albuterol with their normal saline respiratory therapies, close it up, put the face mask on the patient, and this goes to the oxygen in the wall. They titrate the oxygen, it might be 10 liters. Usually the oxygen is high, so they can deliver the medicine with it. Do not stop the patient that's getting respiratory treatment via a nebulizer to feed the patient or take the temperature. Anytime you remove the face mask with the nebulizer, what do you think is happening to the medicine?
Wasting it.
It's wasting. They're losing that. So just go back. I see people all the time trying to interfere with this. Or the patient will be talking to you, or you stay there and be asking patient questions, then they have to take it out to talk to you. Stop talking to the patient, let them finish their breathing treatment, you go back. Because all is happening is wasting the medicine. So these are different ways of administering the medicine. Any question with acid-base imbalance? When the pH is within normal range, you don't have to do anything because the goal of acid-base imbalance is for pH to be normal. So once it's between that 7.35 to 7.45, you have achieved the equilibrium. You have achieved your balance. You don't have to do anything, regardless of what the PCO2 is. Like in this case, let's say that this is the patient that have asthma. The pH is 7.43. Is it normal or not? Okay, let's say this is that patient. PCO2, 31. What will you do? Huh? Do you have to do anything?
Do they still hypoxemic or is it all normal?
Well, let's hope that the O2 sat is not this low. Maybe it's not this low. But even if it's still low, let's say this is 80 and this is 90, you don't have to do anything. Let's say 79. Guess what? pH is normal. You have maintained the equilibrium. The pH is within normal range. Everything else will gradually resolve itself. The goal of acid-base imbalance is for pH to be normal. Once it's normal, you don't have to do anything. Just go about and do other stuff, document what you see that's going on, and just keep moving. Because the pH is what? Normal. Because those patients are going to have PCO2 that's low. Anyway, that's part of the disease. pH is normal. Every other thing will gradually resolve. There was a time in the hospital, I had to pull out a patient that have arterial blood gas. For 2 days, they keep doing this arterial blood gas. The pH keep going up and down, they keep doing it. Once it was 7 point, it looks like they were waiting for the pH to get closer to normal. Once it was 7.35, you don't see any more. They didn't do any more arterial blood gas. Why? Because the pH is normal. Why waste my time here? They didn't do it. I couldn't find that paper. I was looking for it. But it was somebody arterial blood gas in the hospital. If you look at the pattern, they keep doing it because the pH is never within normal range. They kept doing it. Once it was 7.35, there's no more acid base. So it's something that you have to pay attention because that's what is being done in the hospital. That's why we're learning all this, so we know what to do for the patient. Okay. You know what? Why not take 10 minutes break? When you come back, we continue.
So that patient that you that the pH went back to normal, I mean, it could still go back down.
You can. Okay, so we're back from break. You said that we miss cold air, right? That's good. Cold air is one of those things that triggers asthma attack. What does cold do? There's a what? Constrict. That's why most patients during cold weather, those patients that have a lot of respiratory issues like sickle cell, COPD, asthma, they come to the hospital a lot during cold weather because of that vasoconstriction of the airway from cold air. So let's continue. Well, let's look at medication or pharmacological treatment or medication, commonly called medication. So what is the first medication? Look at that sheet of paper I gave you about those two patients. Those two MARs. Let's bring yours out. Remember the MAR of two different patients that I gave you that have two different diseases but similar medication. So what is the first medicine there? You have your paper, right? Okay, so let's look at it. Albuterol. What is the next medicine on that paper, on the MAR? Hypertropium. Hypertropium. Bromide. Then which one is the anxiety medicine that's listed in the MAR? If you flip in the back of that MAR, which one is for anxiety? Alprazolam. We can add diazepam, methylprednisone, and then prednisone. Okay, albuterol. What do we say albuterol is? Albuterol is short-acting beta blocker, right? Short-acting beta agonist, not beta blocker. You don't want to give beta blocker. You want to give the short-acting beta agonist. What does he do? How does he kick in? What does he do? It's a broncho what? Dilator. It's a bronchodilator. It's short-acting, so it kicks in what? In minutes, but it lasts up to 4 hours. When a patient have asthma exacerbation, you want to start off giving them the short-acting beta agonist. You want to give them albuterol inhaler. Usually in the hospital, it's given via nebulizer, like I just described earlier. That's what the patient gets all the time, via nebulizer. You see them steaming with air. They use the normal saline. Respiratory does that. So start off with that. Because it's short-acting, it kicks in immediately. You want to bronchodilate that airway before you give more medication. So what does the hypertropium do? It is a long-acting bronchodilator also. LABA, long-acting bronchodilator. Because it's long-acting, it takes a long time to kick in. Do you think you need to start off with that, or you want to start off with short-acting when the patient has it? Why? You don't want the one that lasts a long time? That
You need to start acting immediately.
right. You want to start with short acting. You want the one that kicks in immediately to bronchodilate that airway before you give the patient anticholinergic, which is iprapropium. Always start off with fast acting. If you need to give patient any other medicine, start out with the short acting first. Then you can start giving any other. Give the bronchodilator first. If you have to give bronchodilator and the anti-inflammatory. Bronchodilator first, then anti-inflammatory. Alprazolam and anxiety. They both for anxiety. Why do they have anxiety? Why does those patients with asthma exacerbation have anxiety? Because they can't breathe. What makes them not to breathe? Why can't they breathe? Well, lack of oxygen. What is causing that oxygen from? Constriction. They cannot breathe because of that chest tightness. Because of that chest tightness, they're not getting enough oxygen in the lungs, right? So they feel like feeling of doom. They're hyperventilating. from that anxiety. It is the anxiety that predisposes them to hyperventilation because they don't know when the next oxygen is coming. They're feeling like they're drowning in themselves, no oxygen coming in, and I don't know when the next one is coming. So that feeling of doom is what makes them hyperventilate. So you need to give them anxiety to calm that, don't give them anxiety. You need to give them, give them alprazolam and or diazepam to calm that anxiety down so they can focus on the breathing. Because when they're anxious, they're not breathing, they're panicking. We need to calm it down so they can have opportunity, concentrate on breathing effort. You don't give those patients that have asthma beta blockers. Why? Why don't you give them beta blockers? What does beta blocker do? Bronchoconstriction. Do you want to give them anything that will bronchoconstrict already when they're already struggling with airway that's already constricted? No, you don't want to do that. So beta blockers are contraindicated on patients that have asthma. You cannot give it to them. Let's go back to ipraprotein bromide. How many of you have your drug book? I told you to bring your drug book. Turn to page 844 and tell me what the contraindication is. Page 844 of your drug book. Tell me what is contraindication on a patient that have ipraprotein bromide. Anybody? Let not all of you shout at the same time. Page 844. Page, are you in 844?
859 in our book.
Okay, look for caution. Caution use. I don't know if it's the same terminology in your book. Okay, what is the caution?
Narrow angle glaucoma, PPH.
It is contraindicated in patients that have what? Glaucoma. We have to read our books. We have to use these books. We have to use them. So patients that have ipraprotein bromide is contraindicated in patients that have glaucoma. They cannot use that. Okay, so any questions here? So let's talk about prednisone, steroid. Steroid is one of those medications that's very, very nice. Prednisone or methylprednisone, we're just going to take one and just, they're all steroid. Steroid is an anti-inflammatory. It's medicine that works very well, but you cannot use it for a long period of time. Cannot use it for a long period of time. Prednisone is usually taken by mouth. So what are the side effects of steroids? Increased sugar. So hyperglycemic, right? Hyperglycemia. What else? Weight gain.
Don't it make your pressure low?
Hypertension. Low immunity, immunosuppressant. I don't know it like that, so.
Insomnia.
Huh?
Insomnia.
I don't know it with insomnia. It does insomnia.
Dry mouth. Being hungry.
Let me just do the one I'm sure. I don't want to put something I'm not sure of there. What else? What does it do to potassium level? Decrease potassium level. What does it do to sodium level? Increase sodium level. It can also cause osteoporosis. Weight gain, we have it here, hyperglycemia, hypertension, sodium, edema. It kind of causes moon face. Those people, their face is always puffy. Moon face, puffy. You can look at somebody and know who is taking a prednisone. It also can cause bleeding. Causes bleeding. Okay. A patient with asthma exacerbation comes to the hospital. The patient is taking prednisone or methylprednisone or any form of steroid. What do you expect to see? A. What do you expect to see? A. Blood sugar 70. B. Blood pressure 130/70. C. Temperature 101. D. Sodium 132.
C.
What do you expect to see?
C.
C. Why C?
Increased risk for infection.
Yeah.
So what makes them increase risk for infection?
Say immunosuppressant.
Immunosuppressant.
Very good.
Corticosteroids, muscle.
This is how I want you to learn it right there. Because this is what you're going to be doing on the patient to be able to interpret these. This is how you're going to see it on the patient. You're not going to say, oh, you have osteoporosis, edema. No. You're going to say, oh, the patient temperature is 101. Or like the patient we took care of last week. The patient is 7226 that's getting methylprednisone. We keep giving the patient insulin. Huh? Why? Because he keeps getting prednisone every so often, IV. That's why the sugar stays high. We keep giving her sliding scale in addition to scheduled insulin. So that's the patient that the blood sugar stays in the 220. Well, you won't have this there, though. You can just say temperature 98 or whatever. Patient blood sugar is 220. Is that what you expect to see? Yes, because it increases the production of corticosteroids that increases what? Blood sugar, which is what you are going to test on the patient. You are not going to be testing the corticosteroids, but you sure will be doing a check, right? So that's how you do that. Put all these things perspective into the patient. This is what you're going to be doing to interpret these signs and symptoms that you already know that those medicines cost. You're going to be doing a check. You're going to be doing all this. So this is how I want you to learn that. Any questions? Okay, very good. So this is medication. A patient with asthma comes to the hospital. Patient with asthma exacerbation comes to the hospital with shortness of breath. No, this might be a little. Patient comes with coughing, pH 7.46, no, pH 7.43, PCO2 29. What will you do first? A. Give oxygen. After all, we're talking about asthma, right? So B. Check. Check arterial blood gas. C. Assess lung. D. Document what you see.
A.
C. C and then D.
C.
So, show by raise of hand. How many of you says A? Why not? Oh, one person said A. Okay. So one person said A. So 2, check arterial blood gas. Nobody? Okay. C, assess lung. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. This might be a little confusing. Well, let's say half the class. Document what you see.
I mean, I would do C then D.
Tell me why you document what you see.
There's nothing saying that it's abnormal with the arterial blood gas.
You mean to tell me I spend all this time explaining this and you're picking answer here? 7.443, is it normal, abnormal, or normal?
Normal.
Okay, so what will you do?
Nothing.
Do nothing.
Well, I would just listen to the lungs because she's an asthmatic patient and she's coughing. So I would still listen to her lungs.
Let's just hope you won't be this close.
Okay.
Let's just hope you won't be this close. We can just say reposition the patient. Will you reposition the patient?
No.
Okay. If I put that there, what will you take?
Doctor, what you say?
Right.
Yeah.
The goal of acid-base balance is for the pH to be what? Normal. That is the goal. You call it acid-base imbalance. That's what you spend an hour in class or 2 hours talking about. Acid-base what? Imbalance. When the pH is normal, it's already what? Balanced. The goal is for pH to be normal. When pH is normal, you don't have to do anything. Every other thing will resolve itself. I don't know how many times I'm going to say this.
Okay.
I even used the examples of the patient we have in the hospital, and that was a fact. I just don't have it presented like we are doing acid-base balance. You see where the result is. Once it gets to normal, even though all this other stuff are abnormal, they stop. Because they're wasting that's fraud, Medicare, Medicaid fraud. If you keep doing it, because you already resolved what you're looking for. Every other thing is treatment you have to do for the patient, do other stuff.
It's not this one, is it?
No, this one here is, the pH is abnormal on that one, right? Okay, so please pay attention to these things. They are very important. It's very important because that's how you care for the patient. Like I said, that's how the doctors do things. There's nothing that's manufactured out there. You have to do it based on these arterial blood gases. Respiratory will put it in. The doctor will look at it. So, obstructive sleep apnea. What does obstruction mean to you? Blocked. So, what is the most important thing that we don't want to obstruct that is happening here? What are we lacking? What is this patient lacking? Oxygen. So when a patient have obstructive sleep apnea, this patient can have period of apnea. What is apnea?
No breathing.
No breathing. There's cessation of breathing for 10 seconds for those patients. They sleep. In their sleep, within 10 seconds, they stop breathing. Then they wake up again, breathing. At that time, they're not breathing. Are they getting oxygenation in? No. So those patients that have sleep apnea stay in respiratory acidosis because they're returning this CO2. They're not exhaling. They have period of apnea that they're not getting oxygen in. Always remember, oxygen and carbon dioxide are competing the same spot, alveoli. It's all about this alveoli where the gas exchange occurs. So when you have too much CO2, you're going to have less oxygenation. When you have too much oxygenation, you're going to have less CO2. You want more oxygenation and less CO2. So anytime you have increase in CO2, that patient is going to have less oxygenation. So with patients with sleep apnea, they're in respiratory acidosis, they have a lot of CO2 retention because they are hypoventilating while they're sleeping. They're having this period of apnea, they're not inhaling so that they can get oxygen in. Period of 10 seconds. There is a test we call polysomnography. Polysomnography is the test to test for sleep apnea. They put the patient in the room for 24 hours while the patient put a lot of electrodes on the patient. They have polysomnography tests. That's all they do. I don't know why I don't have that kind of job. I just sit down and just check stuff off. and get paid. That's what they do. So when that patient is hooked up on that, they monitor the patient heart rate. They monitor their heart rate. They monitor their breathing. They monitor their eye movement, eye and leg movement. Eye and leg movement. Heart rate, breathing, and eye and leg movement. That's all they monitor in that polysomnography to see how well the patient is sleeping or not sleeping before you can be qualified to say that you have obstructive sleep apnea. Not somebody who snores. Because I know my husband snores.
Yeah.
But he's not going to be qualified for sleep apnea because he doesn't have apnea. So not everybody who snores. Most patients that have sleep apnea, obstructive sleep apnea, are 45% overweight. They are mostly 45% overweight patient. So when they do have this sleep apnea, so what do you think are the signs and symptoms they're going to have? They're going to have fatigue. They're going to have daytime sleepiness. They sleep in the daytime. Daytime sleepiness. They have headache from not sleeping. They're going to have hypertension, high risk for stroke. What else? Overweight. Weight gain. Respiratory what? Acidosis. So this patient, what else? Okay. A patient comes to the hospital with obstructive sleep apnea. What do you expect to see? A, blood pressure 100/80. B, respiratory alkalosis. C, weight loss. D, no. O2 sat 100%. No. Well, of course, this one will give itself away. I don't want to do it like that. Well, O2 sat 100%. I'm going to just put this here. Weight gain. This will just give itself away. But yeah, but the point I'm trying to make is this is how you learn it. Put it into the patient perspective, what you will expect to see in the patient. It's not enough to learn it in isolation. Oh, they're going to have headache, hypertension, this. Okay, what? What's going to tell me that they have that? Is their blood pressure 100/80 or is it 190/90? Is their O2 sat 100 or did they gain weight or lose weight? Are they in respiratory alkalosis? They're in respiratory acidosis. So if they are in alkalosis, they don't have apnea, they have asthma. So put it into perspective on a patient, how these things, signs and symptoms work, and what you need to do about them. So these patients that have sleep apnea, they don't sleep well in the night. Because they don't sleep well in the night, they get headache. So treatment. What are the treatment for them? CPAP or BiPAP and BiPAP. What does CPAP stands for? Continuous positive airway pressure. Because it's continuous, you see it in the hospital, big bulky machine, but now they have some you can use at home that are smaller. So this patient that have sleep apnea, for a patient to be qualified for CPAP, in as much as you have to have that obstructive sleep apnea test done to be diagnosed for obstructive sleep apnea and not the fact that you're snoring, they have to be patients that are awake. they have to be awake to use CPAP machine. Those patients cannot be in restraint. You cannot give patients that have obstructive sleep apnea any like narcotics. You cannot give them narcotics because they're already sleeping. They're already hyperventilating. They already don't sleep well at night. You don't want to give them sedatives. That's the word I'm looking for. You cannot give them sedatives. So those patients that have apnea, you cannot give them sedative. For them to be on CPAP machine, they have to be awake, alert, and oriented. That's the patient that can cough on their own. This is the patient that can eat, talk on their own. For them to be qualified for CPAP machine. Again, let's look at our skill book. How many of you have your skill book? Nobody. Page 489, 487 on your skill book. Okay. Who else have their skill book? Okay. Turn to page 489, 487. And look at the CPAP. You see how it looks when you look at it? Page 487. Can you read the safety consideration on that? Brown?
Patients using CPAP and BiPAP are constantly at risk for aspiration and subsequent respiratory complications. The candidate must be alert and responsive orally, must demonstrate airway protective measures, cough in and swallow, and must not be restrained or sedated. Opioids relax the pharynx and contribute further to airway obstruction. CPAP and BiPAP should never be used on a sedated patient. There is a great danger of aspiration should the patient vomit.
Thank you. It's no different from what I just said. Why did I do this? So that you all don't think I'm reading off the book. I don't know what I'm saying. The book says exactly what I say. Why? Because I read the book. I don't manufacture this information. I have to read the book myself. So it is important we read our books. We have to read our books. So those patients that are in CPAP machine, because it causes aspiration, they have to be a patient that's awake, so that if anything comes up, they have to swallow or spit out. They will be able to do that. You don't give them sedatives. Everything I just said, you don't give them sedatives. You cannot restrain a patient. I mean, they're not combative. So there's no need to restrain them. Or any patient that is unrestrained for something else is not no more a candidate for CPAP machine. Because they need to be able to breathe. They need to be able to work with their respiration when they're on the machine. And in addition to that, CPAP machine causes dry mouth also. It causes dry mouth. So those patients, you have to take care of them, with their mouth moisturized or something. So it's very important we understand this concept, because you can't just recommend CPAP machine for any patient if they're not qualified. It can cause more harm than good. You don't want that patient to die from you trying to rescue the patient. So CPAP and BiPAP are kind of like the same thing. While CPAP is continuous passive airway pressure, it forces air in, but the patient exhales on their own. When the BiPAP, bi means what? Two, forces air in and forces air out. So the the BiPAP, puts air in, takes air out. While the continuous passive airway pressure continuously puts the patient air in while they're sleeping. So you see why they have to be awake. They still have a role to play in this whole scenario. They cannot be sedated. They need to be awake. Patients have to be talking. Patients have to be able to cough on their own, so that if they need to cough, they need to cough. So very important concept. Back to asthma, something I forgot to say. When a patient have asthma, after all the treatment we give them, if the treatment does not work, let's say in 24 hours, the asthma is not responsive to any of these treatments, the patient needs to be transferred to ICU. Because now the patient is going into status asthmaticus. Status asthmaticus is a medical emergency. Status asthmaticus. It is a medical emergency. Remember, I told you that patients that have asthma exacerbation, they hyperventilate. When they are in status asthmaticus, they are hypoventilating. Now they have gone from respiratory acidosis to respiratory alkalosis. So absence of wheezing does not necessarily mean that the patient is getting better. Why is that? Absence of wheezing does not necessarily mean the patient is better. Why do you think so?
Eventually the airways can close on them.
Right. It might be complete occlusion of the airways. So with complete occlusion of the airways, there's no gas exchange. You're not going to hear anything. So absence of wheezing does not necessarily mean that the exacerbation have resolved. The patient might be in respiratory acidosis at this time. At this time, they might be hypoventilating, which is a dangerous situation for a patient that have asthma. Asthma exacerbation, they are in respiratory alkalosis. Once it converts to respiratory acidemia, which is suppressed respiratory center, because of more occlusion of the airways, the patient is in status asthmaticus. It's a critical emergency. They need to be transferred to ICU. You need to say something? Oh, you just scratch it. Okay. So this is a critical emergency you need to pay attention to for a patient. Okay, any questions?
You said that if the treatment doesn't work within 24 hours,
In 24 hours, yes.
like the medicine, like the inhalers and everything.
The inhalers don't work, the treatment don't work. If they have infection, including antibiotics they receive it, the patient just don't get better. The patient peak expiratory flow rate is never hitting 80. The patient is not responding to any treatment. They just don't look right in 24 hours. There's no time in wasting time. Patient needs to be transferred to ICU to be intubated.
You might hear the absence of, you might not hear the wheezing.
You may not even hear wheezing. And the absence of wheezing does not mean that the patient is getting better. It might mean complete occlusion of the airways. Therefore, there's no gas exchange, so you can't hear anything. Again, those patients need to be transferred. Or rapid response. You start off with rapid response and then patient will be transferred. Any questions? Okay, so let's go over our PowerPoint. Asthma, recurrent episode. We already went over this. Stop me if you have any question because I've talked about all this already. Asthma in any life might lead to airway remodeling. It might affect their airways. This is how a patient that have asthma look like. They feel like they're trapped. That chest tightness, they feel like they're squeezed. It's not expanding. Pathophysiology, acute inflammatory response, inflammatory mediators released, causing impaired airway clearance. They're coughing, they have a lot of sputum that they need to cough out. Increased workload of breathing, they're hyperventilating, they're breathing fast. Trapped air mixed with inhaled air, causing impaired gas exchange on the patient. Give them oxygen, give them their inhaler. Bronchodilator first, oxygen, raise the head of the bed. Of the same signs and symptoms with COPD, the same intervention. Attacks that prolong 4 to 12 hours after exposure. Prolonged bronchoconstriction, airway resistance, hyperventilation can lead to respiratory alkalosis because they're hyperventilating. They're going to have respiratory alkalosis. Their pH will be greater than 7.45. Allergen irritation talks about immunoglobulin. Another important concept we have to watch for. When we do CBC, for patients that have asthma, we have to do CBC with differential. You can just do CBC, you're looking for patient H and H, but when you add differential, that's where you're going to get like eosinophil. Eosinophil is a marker that tells you inflammatory responses going on in a patient. So you can see CBC with diff. That's what the doctors are looking for, inflammatory responses. So normal eosinophil is like 1 to 4%. When the patient have asthma exacerbation, it makes it very high. So that tells me that's what they do. So when these immunoinflammatory responses, because of the triggers, patient will start wheezing, tightness, dyspnea, and coughing. Asthma trigger, allergy, air pollution, respiratory tract infection, exercise, cold air, stress can trigger asthma. Medications, GERD, Patients that have asthma and COPD, or any patient, you have to educate them to be careful with over-the-counter medication. Because some of these over-the-counter medications, some of them you don't even know what they do. St. John's wort and all these other things. People are taking one thing for diet and this and that. They have to be very careful when they have asthma, because you don't know which one is countering the medicine that they have. We already know that beta blockers, they cannot have that, because again, it causes bronchospasms. So we need to be careful with that. Assessment wheezing, arterial blood gas, peak expiratory, we already discussed this. Eosinophil, it's an increase in allergic response. When you do CBC with DIF, you'll be able to pick up eosinophil. Clinical manifestation, we already talked about this. Asthma can be insidious or it can be abrupt. You can be talking to the person, all of a sudden, they will start having asthma exacerbation, especially when they're close to their trigger. Anything that triggers their asthma, that's why they have to carry their albuterol inhaler wherever they go. Diagnostic test, we have talked about all these: CBC with DIF, pulmonary function test, O2 search, pulse ox. You have question? Or you just stretch it? Okay. O2 SAT, we use that all the time. Pharmacological therapy, the goal of pharmacological therapy is to prevent and control the symptoms. We want to prevent those asthma attacks, and once it already happened, we want to control that so it doesn't exacerbate. Inhale short-acting beta agonists for quick relief. That's why it's called rescue inhaler. Those short-acting beta agonists are called rescue inhaler because they rescue the patient during the time of exacerbation. Med administered, we already went through all this. Because we're not going to learn about the whole medicine in the whole world, otherwise we'll be at Xavier, which is pharmacy school. We have to learn the ones that are mostly used. That's why I brought these two MAR, so that we can see patients that have, two different patients that have oxygenation, alteration in oxygenation, what type of medication that are commonly used in the hospital. That's why I brought the actual MAR, so that we can see the most commonly used medicine in the hospital, and that's what we're learning. Corticosteroids, we've talked about that. Like I say again, we can't know all the medicine. Implementation, promote effective gas exchange. Monitor the patient's skin. When you go in the patient room, please turn the light on. Some patients don't like their light on, but you're not going to be able to assess the patient's skin if the light is not on. Ask the patient, can I turn the light on? When I finish, can I turn it back off? I will turn it back off. Let them know that you're turning the light off for them. Oh, I got a report last night, the nurse said your oxygen sash dropped. So I want to look at your color to see how your color is looking now, to see if your oxygen is back. When the patient knows that you're doing something for them, they will comply. But if you don't explain all that to them, they think you're doing something just because the doctor wants you to do it, and not because you're doing it for them. They will say, oh no, ma'am, I don't like my light on. I don't care what you say. I never turn my light on at home, and I'm not going to turn it on today. Then you're going to have patients that's dying. You can't even see that they're sweating profusely. So turn that light on. Put the patient in high Fowler. They breathe better. The lung expands better when they're sitting up. Give oxygen. Nebulizer treatment. Call respiratory for nebulizer treatment because they are the only one that does the nebulizer. We can do the inhaler for them. But when they are very sick, they need a bronchodilator immediately. They're exacerbating, they need their nebulizer because it comes in aerosol, goes directly to the lungs. And then it's humidified. Anytime you have a patient that's on nasal cannula, O2, on nasal cannula, anything more than 2, you have to humidify it. So O2 at 2 liters is fine. Anything more than 2, call respiratory to come and put humidifier. Because what this does, remember, it's oxygen, is air, it dries the nasopharyngeal area. So when they humidify it, it kind of mixes it up with moisture so the patient can tolerate it better. Patients are looking for anything to take away anything that they are hooked up to. Anything that's hooked up on the patient, they don't want it to last too long. So unless they really need it, so you have to make it easy for them to tolerate. Otherwise, they will take it off. You go in the room, it's in the bed, even though they can breathe. Administer nebulizer, increase fluid intake. For that coughing, thick sputum, give them fluid 2 to 3 liters a day, right? Do you see similarities between COPD and asthma? It's the same thing, the same treatment, the same signs and symptoms, maybe 1 or 2 variations, the same treatment. Because it's alteration what? In oxygenation. Enhanced breathing pattern, the same thing. They have breathlessness from those chest tightness. So what will you do for them? Monitor their vital signs, space the activity level, rest between activity, monitor the arterial blood gas, give medication, bronchodilators, help relieve anxiety, give them those diazepam and lorazepam, cool off the anxiety so they can breathe better. Concentrate on breathing, not the anxiety, whether the oxygen is coming or not. So that will help. Promote adherence to therapeutic regimen, provide education regarding activity. Status asthmaticus, clients at risk for respiratory failure, symptoms are more severe and more prolonged. Respiratory acidosis. They're starting off with respiratory alkalosis when they have asthma exacerbation. But if it doesn't respond to treatment, there's severe more occlusion of the airways, no air coming in, no air going out because of bronchoconstriction, more narrowing of the airway. That can predispose the patient into respiratory acidosis. It's a critical emergency. Patient can have respiratory failure. Therefore, they need to be transferred to ICU to be intubated. Obstructive sleep apnea, they have 3 different types. Don't worry about the types. Just know that it's obstruction and sleep and apnea. Just know that there's decreased oxygenation. They have period of apnea that lasts up to 10 seconds. So that means that for those 10 seconds, there's no oxygen getting in. The body accumulates the CO2, oxygen not coming in, they're not exhaling because they have apneic episode. So that increase in accumulation of CO2 predisposes them to respiratory acidosis and hypoxia. Predisposes them into having headache, they sleep in the daytime, they're not having enough sleep. This YouTube is a mess from different classes, so I'm not even going to worry about that. It won't come up right, so I don't know what's going on, but I've been using this for 2 years now, and it was working. It didn't work right today, so we're going to skip that. But what it's all about is what I just explained to you. When those patients lie down, the uvula comes down, closes their airway. So they're sleeping for 10 seconds, no breathing, that's that apnea period. Then they wake up and then gasp for breath again. That's all this video is talking about. It's about that apnea period. Different types, still they have occlusion. Polysomnography, I talked about it, is done overnight. Record oxygen level, heart rate, breathing, and eye and leg movement to be able to know if the patient is qualified to be diagnosed as obstructive sleep apnea, not just that they're snoring. Assessment, daytime sleepiness. They sleep a lot in the daytime. Why? Because they didn't sleep at night, right? Loud snoring. They have period of breathing cessation during sleep. Abrupt awakening. They just sleep. Then they get short of breath for lack of oxygenation because they're lacking oxygen. That 10 seconds, they didn't take in air. Awakening with dry mouth and sore throat because they always breathe with their mouth open. That's another thing. CPAP also causes dry mouth. CPAP causes dry mouth. So you have somebody that has sleep apnea that causes dry mouth because they always breathe with their mouth wide open, causes dry mouth, plus CPAP itself causes dry mouth. They get morning headache because they didn't sleep at night. Difficulty sleeping, insomnia. Of course, they have this period of apnea, so they keep waking themselves up and going back to sleep, only to find out they're waking up again to catch breath, go back to sleep, period of apnea, they wake back up. So this is cycle. That's why they sleep in the daytime. Risk factor for stroke, of course, they have hypertension, they have decreased oxygenation. Because of increased accumulation of CO2, less oxygenation. So increases their blood pressure, decreased oxygenation, increased carbon dioxide in the blood, respiratory acidosis. Non-pharmacological, position, weight loss, educate them on their diet. So what kind of diet do you think they need? What kind of diet? They're overweight, 45% overweight, low sodium, low fat, low cholesterol, right? High fiber diet. Avoid alcohol. Alcohol is a sedative. Remember again, they cannot have sedative. They don't sleep well. They're already having period of apnea. They're already having suppressed respiratory center. They're already hypoventilating. You don't want to give them sedative. You don't want to give them anything that will make them go to sleep because they already don't sleep well. They're already retaining a lot of CO2. If you give them something to make them go to sleep, they might die because now they already have increased CO2. This is what is killing people in the community from drug overdose. What is killing people from drug overdose is respiratory acidosis. Because they're already suppressing their respiratory center. Keep taking these medicines, suppressing and suppressing, accumulating CO2, suppressing their respiration. They're not inhaling it. You can only get oxygen when you inhale. You're not inhaling, you're storing all this acid in yourself, which is CO2. Because carbon dioxide acts like an acid. You're keeping all this CO2, you're going to have respiratory acidosis, and they can die from that. So avoid supine position when you're sleeping. Educate them to lie on their side. Avoid supine position. We already talked about BiPAP and then CPAP, the same thing. Pay attention to the CPAP and BiPAP. How are they being used? What kind of patients are qualified for that? Because not every patient is qualified. No sedative for them. They cannot be on restraint. They have to be awake, alert and oriented, because they need to be breathing on their own, with the assistance of the CPAP. CPAP is not they're not like in ventilator. If anything else fails, then surgery will become. The doctors will go either take the uvula or do something in their uvula. Either they cut it down or cut it off. So I don't know.
So the uvula is the problem more than the tongue?
Sometimes the tongue, but it's not really necessarily the tongue. It's the uvula that comes down and pulls the airway. But if you lay on your side.
Does it serve any purpose?
What?
The uvula. Other than just hang there?
It serves a purpose. It must have been serving a purpose. And then some tongues, though, some people's tongue can occlude their airway too. But all it's in combination of that. That's why when you lay on your side, your tongue kind of moves out the way, so that you have more room between the uvula and the tongue to work with. Any other question? Muchas gracias.